I'm Amir Fasihi. I'm the founder and CEO of Amnion Life Medical Devices. I'm a radiologist practicing in Orange County, California. And the genesis of this company started out in 2013. We had a family member who had an extreme preterm infant, little girl who spent months in the NICU. And when she was discharged, she had developed both neurological and some ocular injuries and disabilities. And I realized at that time that these infants need to be in a fluid environment. And I hope that I can convince you that these infants suffer because they're not in a similar environment as a mother's womb, and we need to have better devices. So the AmnioBed is a device I'm presenting to you today. At a very high level, preterm infants, when they leave the gold standard medical device, which is the mother's womb, they need thermal regulation, appropriate heat, balance, food management, oxygenation, nutrition. There's been a lot of work that has been done on oxygenation, nutrition. Our device is mainly focused on thermal regulation and fluid management. When you say thermal regulation, we want to prevent hypothermia in these infants. There are about 400,000 infants that are born preterm every year in the US. About 100,000 of them, like my family member, are very preterm and extreme preterm, and they spend sometimes months in the NICU. About 3 million globally are in this category. And in the US, about $26 billion is spent for immediate care for these infants. When these infants are born, one of the main concerns is risk of hypothermia. They have very little subcutaneous fat, very thin skin, so they lose tremendous amount of heat very quickly. And 4 out of 10 of them in the first hour are cold. By the time they're admitted to the NICU, 15% of them are moderate to severe hypothermia, despite the best case efforts, because the body habits of these infants are just not made to retain heat or even to generate some of the mechanisms that term infants have, like shivering and brown fat. So what happens when you have a cold stress to any mammalian organism, and much less a very critical time in life? You get respiratory distress. You have a severe stress reaction causing hyperglycemia. Then you have increased metabolic rate leading to hypoglycemia, acidosis, anemia, and then you have end organ damage, neurological injuries, respiratory distress syndrome, sepsis, weight loss, and ultimately death. 30% increased chance of death within 72 hours for every hypothermic episodes in these infants. So our solution is AmnioBed, a partial submersion of the infant into mineralized fluid that resembles the amniotic fluid in the mother's womb. We have worked on this for a number of years, and it requires significant complexity, mechanical, electrical safety mechanism that protects the infant from drowning, and also make sure the temperature, osmolality of the fluid is appropriate. There are two versions of this device. One is the AmnioBed Golden Hour. It's a device that's used up to 60 minutes. It goes into labor and delivery units or in the operating rooms. And then there's the AmnioBed 24 hours, where it goes to the NICU, where the infants can stay there 24 hours up to 28 days. The benefits are temperature regulation, like the womb, improved fluid management. These infants can absorb both water and also pharmaceuticals such as epinephrine at very critical times when they need it and they don't have IV lines. We can actually administer to the fluid, and the thin skin actually absorbs all the pharmaceuticals, and that's been shown in lamb models. And also protecting the skin that sometimes leads to infections and sepsis for these infants. The current standard of care is it's about 100 years old. It's a boxed incubator, heated, humidified, but there are very shortcomings, drafts of cold air coming in and out with every opening, and then it taking time to really achieve and re-achieve optimal temperature, humidity levels. We've had a number of accolades. Second place in Cleveland Clinic's Medical Innovation Summit in 2019, third place at UCSF Stanford Pediatric Device Consortium, and we are part of the UCSF Pediatric Device Consortium Accelerator. I put significant amount of emphasis on patent portfolio. Initially, we represented one of the top medical device patent representatives, Konobia Martin. We have a patent family here in the US, a patent protected in China, Japan, pending in Europe. We also have a China divisional application ongoing there as well. The regulatory strategy is a global strategy. Our R&D facility was set up in Serbia, and we have developed a considerable amount of network of individuals, expertise in medical device development in Serbia, Macedonia, and Bulgaria. And Bulgaria is a part of EU. We hope to get CE mark there first, going to Asia, and then using the real world data for the US. Each amnio bed, excuse me, I got distracted. Each amnio bed is expected to cost $150,000 for the hospitals. We're trying to put together a lease program to bring it down to $2,000 per month upfront, and then each use of the device will be about $250. The cost for us about $45,000 for the parts, another $30,000 for sales, distribution, so about $79,000 for total cost. So the capital equipment, the margin is about 40%. For the per use items, the plastics, the cartridges, our cost is about less than $50 per use. So it's the margin is about greater than 70%. And the first question you need to ask is who's going to pay for this? We each day in the NICU costs $3,500 to $9,000 a day, and these infants are on average weeks and weeks beyond their due date, or 36 weeks, which is safe. Each day that we save in the NICU, 15 days of the use of the device will pay for 1 day the reduction. If we have 3-day reduction in use of the device, you can have $1.1 billion in savings. We believe we can have up to 3,800 units active operational in the US in year 8, and about 3,700 in the rest of the world. It's about $150 to $700 unit per sale in the US. And that can generate revenues about $760 million, about 50% margins. We can also expand into the adult market. I'll talk about that, but end of life use of amnio bed is going to be very helpful both for hygienic bath and mineral bath, that a bed that can transform into a bath as well. We've raised $1.8 million through accredited investors, crowdfundings, multiple rounds. Started in 2017, build an R&D facility, build the prototype, and we were paused in December 2020 due to COVID for now. Raising funds until we raise funds again. Very little on the time for the team. I won't get into this. US-based team, also European consultants, but also scientific advisor from Japan, Europe, and North America. The team I built is in Republic of Serbia, the R&D facility, and this is a time lapse of building of the device in our facility. Most of the components are off the shelf, but some 3D components and custom parts associated with it. Raising need $10 million at this round, Series Seed round, followed by a $20 million investment, and then exit expected 27 to 29. Of the $10 million we're raising right now, about $3 million for clinical trials, about $1 million for preclinical testing, $1 million for additional research and development for other devices, and then $5 million for manufacturing and sales. Overall, the device is intended to change the whole concept of neonatal care for these preterm infants. These preterm infants are suffering because of weight loss, calorie loss, fluid loss, and we can do much better. And our
still on
company,
my blacklist.
We hope to be revolutionize care in neonatal world. Thank you very much. I appreciate it.
Thank you very much, Amir. Great presentation. Are there any questions for Amir? You can put them in the chat box, and or you could just ask the question.
So I have a question. With clinical trials, who's going to allow their premature infant to use a untested Amnion versus standard of care?
Great question. So the clinical trials, the way we're doing it is that the first device we have, AmnioBed Golden Hour, is use of the device for up to 60 minutes. Initial clinical trials is going to be on infants, term infants, for 20 minutes. And the reason we do 20 minutes is because 20-minute baths are routinely given to infants, both preterm infants and term infants, and they do actually thrive well in baths. Ours is really a mineral bath. It's a very controlled mineral bath. So we do 20-minute testing first initially, and we're going to be doing it in Macedonia, Bulgaria, and Serbia, followed by, once we show safety in 20 minutes, then followed by 60-minute showing safety, and then we'll go longer to 24-hour use of the device. But initially we'll be on term infants, just a regular bath, which is really what we are. It's a controlled bath environment.
There's another question about why is the monthly cost so high?
For the per use of the device, or the per use of the device, we have projecting at $250 per use. We have to pay for plastics, the cartridges, use of it. It has to go through a disinfection cycle in between each use that is similar to the dialysis cycle that patients go through or dialysis machines go through. So all those costs have to be taken into account, and also the revenue model needs to be taken into account for the company to pay for the research and development and getting this to the market.
Yeah, I mean, excellent presentation. And two questions here. What is the regulatory approval path for this device? And the second thing is that how does this device ensure there is a continuous positive airway pressure? Because that's the key for the NICU kids, right?
Yeah. Okay. So as far as the regulatory strategy, our focus is go through EU first with a notified body. This is a Class 2A device in Europe. Once we and then we're going to piggyback on the CE mark from Europe in other markets in Asia and Middle East. And then we're going to use the real world data that we gather for the FDA, together with some clinical trials, $3 million. I mentioned that we're looking for 3 sets of $1 million each clinical trials. And in the US, we expect it to be a Class 2 device, just like any other incubator, but it has to go through a de novo process because there's no similar devices on the market to it. There's also a chance for us to go to a humanitarian use device program because the infants born less than 500 grams, almost 100% of them have hypothermia and very, very high mortality, morbidity. And there's no device in the market that can protect them from hypothermia. And there's only less than 8,000 of them every year that suffer from that, are born that small of a micropreemie. So there's a chance, other than the Class 2 de novo, that we go through the humanitarian use device pathway as well.
Excellent. Thank you.
Oh, you had another question. Sorry. You had another question. Positive airway path. So as far as airway, our device, we're going to provide the airway for management just like any other incubator. So we don't deal with the airway. We just want to make sure that the doctors have access to the airway at all times, just like any other incubator.
Oh, okay. Okay.
Yeah.